Symptoms. The symptoms of renal tuberculosis usually make their first appearance between the 15th and the 35th year. The disease is very uncommon in childhood. Indeed, Urination has been able to collect only 51 cases of renal tuberculosis in children. Statistical reports derived from the autopsy table show a very large percentage of renal tuberculosis at a relatively advanced age. This is due to the remarkably chronic course of certain cases, which may run from 15 to 25 years, or if actually occluded, indefinitely. Clinical types. 3 clinical types of the disease are recognized, the predominant feature of which are the following: frequent and painful urination, hematuria, renal pain, or colic. None of these types is exclusive. Almost every case of renal tuberculosis has frequent and painful urination as its predominating feature. Almost every case has some hematuria at one time or another. Renal pain is a relatively rare symptom. The bladder type. The mere presence of a tuberculous focus in the kidney causes no symptoms beyond perhaps slight fever and polyuria. When such a focus bursts into the pelvis, it is likely to cause a slight brief hemorrhage. This often passes unnoticed. The disease then spreads to the kidney, pelvis, and ureter, causing painful and frequent urination even before the bladder is infected. The bladder is soon invaded, however, and adds to the intensity of the symptoms. Frequent and painful urination. At first, the frequency of urination is definitely more marked by night than by day, and is accompanied by polyuria, which is also more marked by night. Ureteral catheterization at this early stage will show a marked polyuria from the diseased kidney. The total excretion of urea may even be greater from the diseased kidney, though its phenol-sulfonephthalene output is always less. I have seen but one exception to this rule. Pain may be felt before, during, or after micturition, but the most marked and characteristic pain is terminal, occurring at the end of micturition and continuing for some time thereafter. When intensified by lesions of the trigone, this terminal pain may be associated with terminal hematuria. Hematuria. The hematuria of renal tuberculosis assumes 3 forms, which we may describe in order of their frequency. Microscopic hematuria. A few red blood cells and a trace of albumin occurs from time to time in all cases. Slight visible hematuria, either a smokiness in the urine or more commonly a distinctly terminal hematuria, is likely to occur as soon as the bladder has become considerably infected. Later, this usually ceases. Massive hematuria, renal hemoptysis, as it has been called, is rare, but it may dominate the scene. It occurs early, like pulmonary hemoptysis, and in the absence of other symptoms may suggest neoplasm. Renal pain and colic. Renal pain, while not nearly so common a symptom of renal tuberculosis as hematuria, bears much the same relation to the clinical picture. Moderately severe loin pain, associated with tenderness of the kidney, occurs in perhaps 50% of cases. Renal colic is rare, but may occur at any time from the passage of blood clots or shreds of tissue through the narrowed ureter. Renal pain or colic sufficiently severe to dominate the scene is unusual. Crossed pain. Renal pain may occur in the healthy kidney as a result of compensatory hypertrophy of that organ. On the other hand, severe pain in the opposite loin may be due to lesions entirely independent of the renal tuberculosis. One of my cases had frightful renal colics of this type, which were apparently due to tuberculous seminal vesiculitis. Fever and general symptoms. Slight fever and slight loss of weight doubtless occur from time to time in all cases of renal tuberculosis, but marked fever is rare, and considerable loss of weight is due either to bilateral tuberculosis or to toxemia from ureteral retention. So long as retention is absent and the infection unilateral, the patient may apparently enjoy the most robust health. I shall never forget the first vision I had of a certain woman, Subsequent operation upon whom proved her to harbor a completely destroyed pyelonephrotic tuberculous kidney. As her 250 pounds lay in a hospital bed, surrounded by her anxious family, she apparently weighed as much as all the rest of them put together. But late in the disease, the ureteral lesions are such that adequate drainage of the kidney is the exception. Considerable loss of weight with slight fever is the rule. Such is our interpretation of Israel's statement that he found fever in only 15% of uncomplicated renal cases, but in 80% of the cases complicated by bladder infection.